Okay. How's my hair? Look all right?
Looks great.
Okay. Yeah, I worked on it tonight. So thank you, everybody, for joining. I'm excited to have you here. My name is Erik Dorf. I'm an orthopedic surgeon in Vail. I work with Vail-Summit Orthopedics and Neurosurgery. And topic tonight is rotator cuff tears. So hopefully everybody who is attending this talk is really here just because they're curious about rotator cuff tears and not actually have experienced one um, or dealing with them themselves, but hopefully you're just here for learning. But if not, we're happy to take care of you. So a little background for myself. I grew up here in Vail. I did my undergraduate studies at Middlebury College out in Vermont. I went to medical school at University of Colorado. I did my residency at University of Virginia, and then an upper extremity fellowship at Wake Forest in Winston-Salem, North Carolina. I am upper extremity and trauma surgeon with Vail-Summit Orthopedics and Neurosurgery. I finished my fellowship about 13 years ago and have been working for VSON ever since. I just finished my 10-year reaccreditation from the American Board of Orthopedic Surgery. And even through the COVID pandemic disasters, I have somehow managed to become recertified in orthopedics as well as upper extremity surgery. So pretty excited to get that behind me, and validates our credentials. And it's a little bit of a stressful time, but it went really well, and excited to move on for another 10 years. A few things. I am a team physician for Team Summit, which is a ski team in Summit County, which is just across the pass from Vail. I'm a team physician for the U.S. ski team. It's a picture of myself and Lindsay Vaughn up in Portillo in Chile. I'm also a proud physician for the Cycle Effect. Cycle Effect is a local nonprofit organization who empowers young women around Eagle County, Summit County, and now down in Grand Junction to ride bikes and go to school. So it's another proud thing that I do. My practice is almost 100% upper extremity. I do a lot of lower extremity trauma in the winter, but in the summer, I'm almost all upper extremity. Depending on the time of the year, my practice varies, can be up to 60% hand and 30% shoulder. It's almost always about 10% elbow. Other times of the year, kind of depending on what's going on, I can be as low as 30% hand and do mostly shoulder. So right now I'm about 50-50, which is pretty typical for me. Our talk today, we're going to talk about rotator cuff tears. So again, I hope that this isn't something you're experiencing for yourself, but if it is, I'm happy to give you a little bit of information on it. So a couple of goals for our discussion today. I'm going to try to keep it simple, and then we'll try to answer some questions. Number one, I want folks to understand what the rotator cuff is. What is the function of the rotator cuff? I would like people to understand a little bit more about how the rotator cuff tears, what happens, and that process. Understand the symptoms of rotator cuff tear, how patients present to my clinic if they've torn their cuff, and understand treatment options for tears of the rotator cuff. So let's start with what is the rotator cuff and what is the function of the rotator cuff? Quite simply, the rotator cuff is a cuff of muscles that rotates the shoulder. So this picture actually shows it pretty well. This is a repaired rotator cuff, but it's actually the muscles are all here, and this is up by your scapula, and I'll have more pictures for this I can show you. It's nice to envision this picture because it does show this as a big cuff of tissue. A lot of times people think of these tendons as being very separate, and there are 4 separate tendons, but at the end of the day, they all come out and they insert on your humerus, which is up here, the bone at the top of your arm, and they help to move the arm around. And I'll show you about exactly which of those tendons performs each of those functions. A lot of times patients come to my clinic and they have different names for the rotator cuff. I hear oftentimes the rotator, or my rotary cup, or my rotor, or my rotary cuff, or my favorite one that I hear all the time, the rotor cup. My rotor cup has been torn. So it is not, it is the rotator cuff. And once you understand, that it's a cuff of tendons that rotates your shoulder, it's a little bit easier to remember that. So it's comprised of 4 muscles. One of the muscles is in the front, one is on the top, and then there's 2 muscles that are in the back. Looking at it from the front, so this is a view of a right shoulder, looking at it from the front. You can see this is the humerus. So the shoulder's a ball and socket joint. Here's the socket here. The ball is over here. This is one of the muscles of the rotator cuff called subscapularis. This muscle then comes across, and they've cut it here to show the joint, but this muscle then joins this tendon, and that tendon then comes over and attaches to the humerus. This is the muscle on top. This is the one on the top of the shoulder called supraspinatus. The muscle is here. It continues past this bursa, this fluid-filled sac here, turns into a tendon, and that tendon attaches onto the humerus there. When you look at it from the back, this is again a right shoulder looking at it from the back. Here's that same muscle that we were just looking at. This is supraspinatus, which is the most common tendon that's torn. Muscle comes across, the tendon comes over, and it attaches to the bone. This is infraspinatus, similar muscle, tendon, bone. And then teres minor, which is the least common torn tendon of the rotator cuff. The muscle is here, the tendon comes up and attaches to the bone. You can see how these really look like different tendons here, but in actuality, when we're looking at these with a scope or with MRI, they actually look like one big cuff of tendons that's coming over and attaching onto the bone. So this is a view looking at it from the side as if you were looking into the shoulder like this. This muscle is supraspinatus is on the top, infraspinatus there, a little bit further towards the back, teres minor way around the back, and then that subscapularis would be up here in the front. You can't see it very well in that picture. These functions, or these four muscles, really perform three different functions. That supraspinatus, which is the most common rotator cuff muscle that's torn, moves your arm up and away from your body, kind of like you're raising your hand to your side like this. So if you come into my clinic and you've got a rotator cuff tear, I might ask you to hold your hands out like this and lift your arms up. And that's in order to try to stress that supraspinatus muscle and tendon to see if you've got a tear of that tendon. So the rotator cuff moves your arm up and away from your body. It also internally rotates your shoulder. So it takes your hand from here and it rotates it down like this, as if you're reaching back into your pocket. So it's internal rotation. And that's the two muscles that are in the back. That's the muscle in the front, subscapularis, which is doing that. And then the last function which is the two that are in your back, is as if you're doing this. So you're reaching your hand back like this. And those are the muscles in the back. That's infraspinatus and teres minor. And that's external rotation of the arm. So that's a function. So just to go over that really quickly. What is a rotator cuff? It's a cuff of four tendons that rotate the shoulder. So now we still have to answer, how does a cuff tear? What are symptoms of rotator cuff tear? And what are treatment options for rotator cuff tear? So how does it tear? These tears are all either traumatic or they're degenerative. More commonly, they're degenerative tears. When they're traumatic, they're more common in younger patients. Traumatic tears are more common in younger patients. They do happen in older patients also. Oftentimes, it's from a fall on an outstretched hand or stretched arm out like this, or anybody over about 50 years old who dislocates their shoulder, certainly at an increased risk of tearing that rotator cuff. Now, the remainder of the tears are degenerative. So these are progression of tears from impingement. So we oftentimes talk about impingement, and I'll talk about that a little bit. So where the rotator cuff is actually being pinched by a bone. These can gradually lead to partial thickness tears, which then lead to complete tears. These happen over time, and they're certainly more common over age 50. Most of the time we see rotator cuff tears in my clinic, they're a combination of degenerative or acute on chronic. So it's an acute injury that has happened on top of a degenerative rotator cuff, which is why they happen, very frequently in athletic individuals over age 60 years old who continue to do all the fun stuff that they want to do, but they just had a little bit of degeneration of that cuff over time, and as a result, their cuff is weakened, and they have a fall or do something quickly or lift something, and they tear that rotator cuff. So impingement this is a bone. This is a view, X-ray view of the shoulder. This is the ball, and the socket is actually interposed behind this. So this is a view as if we're looking into the shoulder from the side. The reason we like this view is it shows us really well this hook of bone that's right here. So the ball is here. The socket again is behind this, and that rotator cuff is in the space that I'm outlining right here with my mouse. This spike right here, that spike of bone digs down into the rotator cuff. This is a similar view, now looking into the shoulder again from the side. This is the bone that's on the top, that is right here. This is a ligament that attaches two parts of the shoulder scapula together. The bone grows down this ligament and forms that spike that's right here. And you can see how those tendons of the rotator cuff are all sitting right underneath that, where that spike could potentially grow out. So this is how impingement contributes to rotator cuff tears. And when we're doing surgery for rotator cuff tears, we have to make sure that we're taking care of that big bone spur. It's a big part of the surgery that we do, cleaning that bone spur up. So there it is there, a little better picture. But over time, that spur is rubbing a hole in that rotator cuff, which is trying to squeeze out through this little space right there. And every time you lift your arm up like this, that ball rotates up, and that bone spur is poking down into the rotator cuff, squeezing it, and that's what the term that we use, that it's impingement. So recap again, cuff of 4 tendons that rotate the shoulder. Rotator cuff tears are traumatic or degenerative. Those degenerative ones are often associated with a spur, and those tears are often a combination of a traumatic injury on top of a degenerative tear. What are symptoms of rotator cuff tear? And then what are the treatment options for the rotator cuff tear? 2 more things we got to get at. Okay, so what are symptoms of rotator cuff tear? So rotator cuff, very frequently patients will present to a clinic or to somebody, and they'll have an MRI of their shoulder. They'll come to me with an MRI of their shoulder for one reason or another. And we find a rotator cuff tear in there. And that rotator cuff tear is completely asymptomatic. Somebody didn't even know that they have it. Some people can be very well compensated, even with a full thickness rotator cuff tear. So sometimes those patients are presenting to my clinic with no symptoms at all. Now, these aren't necessarily the tears that we're concerned about. They are common. And a lot of people, as a matter of fact, most people will die with a rotator cuff tear that they didn't even know about. But even though they're really common, they're not very common in my practice, because people don't come to me and saying, hey, my shoulder's perfectly fine. Would you mind taking a look at it? Everybody comes to you with a problem. And so we very infrequently see asymptomatic rotator cuff tears. People come to my clinic for 2 reasons. It's pain or it's weakness. The pain, it's nighttime pain. It's almost always patients who have pain at night. I tell people if it weren't for night times or need for sleep, I would be about half as busy. So nighttime pain is really common with patients who've got rotator cuff disease or impingement or shoulder problems in general. Patients also often come to me with pain with reaching away from their body. They'll come to me and say, hey, Eric, I'm fine, everything that I do down here. But as soon as I go to reach away, or I try to reach forward, or I reach for something off of the bedside table, my shoulder is killing me. The other thing they'll say is I've got weakness, and weakness with any of the motions we talked about earlier, but in particular with doing stuff up overhead. The rotator cuff is really important for doing all these activities that are up overhead. So patients will present to me and say, I'm fine, but I've got a lot of fatigue when I try to lift something overhead. A good example of this is, for example, someone says they're trying to lift something into the overhead compartment of the airplane. That really stresses the rotator cuff. And so I see patients oftentimes who say, I know I was on a trip and I was trying to lift something in the overhead compartment, and all of a sudden my shoulder was hurting. And I've seen a number of patients who have actually torn their rotator cuff, usually taking something out of the overhead bin of the airplane. So when I'm trying to counsel patients on things they should avoid down the road after we've fixed their rotator cuff, that's one of the things I tell people is, hey, listen, imagine that you're taking something out of the overhead bin of the airplane, especially if it's in the seat behind you. That's the thing that you want to avoid, is that sort of up and away from you position. That stresses the rotator cuff a lot. So again, cuff of 4 tendons that rotate the shoulder. Tears are traumatic or degenerative, a combination of the 2. Primary symptoms are pain and weakness, in particular that nighttime pain. So now it's just down to what are our treatment options for rotator cuff tear. So treatment options for cuff tears sort of fall into two different categories. I always tell people, you always have one option that I don't talk about here is you can ignore it. And that's a lot of times what people are doing, especially if they're athletic or they're trying to get through a season or whatever. They're trying to ignore these things for as long as they can. But once you have acknowledged this is a problem for you, then they sort of have to go down one of two options. It's either non-operative treatment or it's operative treatment. It's either surgery or no surgery. Non-operative treatment is giving it time, trying to ignore it, resting, physical therapy to restore motion, pain control with anti-inflammatories or Tylenol or activity modification to help with that pain, or sometimes injections depending on the type of the tear or what our goals are. Surgery, it's just surgical repair of the rotator cuff. And I'm going to go through my techniques and some of the things that I like to do for rotator cuff tears at the sort of towards the conclusion here. So some people advocate for fixing all rotator cuff tears. And this is a picture here of a rotator cuff repair that has subsequently failed. And I very frequently will take care of patients who have a failed rotator cuff. And we go in and we find the sutures that are in there and the rotator cuff repair has failed. So I'm not an advocate of fixing all rotator cuff tears. And there's a lot of disagreement among orthopedic surgeons with regard to what are the proper indications for fixing rotator cuff. It's very variable and there's considerable disagreement regarding the results. The basic tenets of non-operative treatment are basically pain control, restoration of motion, and optimized strength and coordination. Like I said, there are a fair number of patients out there who can have a full thickness rotator cuff tear. And I'll have patients who come to me and we'll get an MRI of their shoulder and they have a full thickness rotator cuff tear that has been there for years and years and years, and the muscle is now atrophied and it's an irreparable tear. And to me, that's a person that really does need to go to physical therapy, and we need to optimize what they have available to them, in particular the other muscles surrounding the shoulder, to try to give them their strength, their coordination, and their range of motion back. But those are patients that typically are not going to do well with a repair of a rotator cuff if they've got a big full thickness chronic rotator cuff tear. If you talk to the insurance companies, they'll tell you that patients who are over age 60 with a sedentary activity demands and chronic rotator cuff tear should be managed with rehab program before surgical repair is recommended. The problem with that, and it's pretty easy to understand if you think about it a little bit, is that if we don't repair that rotator cuff, the muscles will atrophy. You get some fatty replacement of the muscle, and you can get progression of the rotator cuff tears. That tear progression then can cause problems, and those problems include the fact that you can have an asymptomatic tear that over the course of a couple of years becomes symptomatic. So if you look at some of these studies, you see that 51% of asymptomatic tears became symptomatic at about 3 years. The size of the tear increases over time, and depending on the size of that tear, you might see a significant increase in that size of the rotator cuff tear over years. And I talked there a little bit earlier about the fact that some tears, patients will come to me and they have an irreparable tear that there's nothing that we can do about. But if we see those patients early, oftentimes that tear can be fixed. So those are the things that we worry about with regard to tear progression. So, and more important than that, to me, is that I have almost no sedentary patients. My patients come to me because they're active. They want to be able to continue their sports. They want to do things that they do, and they're here in my clinic because they miss those things and they can't do them, and they are older in years, but not in spirit. So this is very typical in my patient population, and a patient population that I'm actually very proud to take care of. These people who have been weekend warriors for about 5,000 weekends. So in order to offer patients an option, we have to have a good option, right? So it's one thing to say, hey, we want to optimize surgical repair, but we have to have good options from a surgical repair perspective. So if you look at all the literature, the results of rotator cuff repair, patient satisfaction scores are really good. Patients do well anywhere from 85 to 95% of the time. And my patient population, I would say, mimics this. I think that our cuff repair re-tear rates are very low. Patient satisfaction scores are very high. And I do think we offer patients a great option with regard to an alternative to non-operative management, which to me, for a symptomatic patient is not that great, especially if you're trying to get back to most of your active sports, unless you have a chronic rotator cuff tear. So if we choose our patients correctly, we use proven techniques that have been developed by much greater surgeons than myself in 25 years that we've been doing arthroscopic rotator cuff repairs. And I feel very grateful to these pioneers in arthroscopy, some of whom I have studied under, who have given us the tools and the skills to perform these repairs. As long as we do appropriate rehab, which is a big deal and it takes a long time, then I do think we have options that are better than non-operative treatment for the right patient with the right tear. So really briefly, how do I do arthroscopic repair? Arthroscopy, as most of you probably know, but not everybody does, it's when we use small cameras to go inside the shoulder. We use several different small holes in and around the shoulder itself. One hole to look through, and then several other holes to use instruments to get into the shoulder to perform our repair. We look at everything when we're in there. We look at the joint, we look at the cartilage, we evaluate the tear patterns. So different tears are more amenable to repairs and use various different techniques. We use anchors to repair. So these are little small plastic anchors. I'm going to show you some pictures of those in a second that we put down into the bone. We tie that rotator cuff down to the bone, and then we basically wait for it to heal. We use all arthroscopic techniques, so that involves arthroscopic knot tying when we need to. And then I use, for almost all of my rotator cuffs, I use a double row repair for the rotator cuff repair, and I'll show you what that means. So this is an example of a double row repair. This is a repair of the supraspinatus tendon, just to give you a little bit of reference. That muscle is over here. The tendon is coming across. This is an instrument that we're using to pass a suture through the rotator cuff. You've got anchor over here, and then you would have another anchor over here. And those two anchors join together, or the sutures join between the two anchors to hold that rotator cuff down to the bone. And that's what we mean by double row repair. And so this is one example of a double row repair here, where you have knots over here and knots over here. And then this is another one here where you've got the sutures that are holding the rotator cuff down to the bone. And this is the type of technique that I use here. Similar view here. So an anchor in here. This is a view looking into the shoulder as if we were looking underneath that bone spur, which would be up in here. The tendon is coming at us in this picture, so it's coming directly towards us. And here's that row of anchors that's over here, and then the other row of anchors would be over there. So again, final recap here before we go on to video to show some of our techniques. Rotator cuff is a cuff of 4 tendons that rotate the shoulder. Tears are traumatic or degenerative, associated with a bone spur, and oftentimes a combination of traumatic and degenerative. Symptoms of the rotator cuff tear, pain and weakness. And treatment options for rotator cuff tear, basically non-operative and operative. And when we use operative treatment of the rotator cuff, I like to do an arthroscopic double row repair. So I've got a video now. This is sort of a combination of a video from my website that shows arthroscopic double row repair, but also a video from one of my cases that we did actually a couple of years ago. We brought out, so hopefully this will share appropriately. Rachel, maybe you can let me know if it's not. Hang on.
Looks like it's working so far.
Okay, I'm gonna make it a little bit bigger there for us. So I'm going to do some of the narration for this. This is the position that we use when patients when they're fixing the rotator cuff. You're sitting up in the operating room with just the arm exposed. So these are the portals that we use to enter into the shoulder. So several small holes, anywhere from 3 to 6 small incisions. These are the instruments that we use, the camera coming in from the side here, and then instruments that we use to pass the sutures, to put anchors in the bone, and to do the majority of the work for our repair. And we're zooming in here right now on the supraspinatus tendon. This is the muscle. Here's the tendon. Here's the bone. This is actually depicting a tear. So a normal cuff tendon would look like this. And you can see up in here, you've got the tear. And we'll have a little better view of that in a second. So there's the tear. So here's me doing arthroscopy on the shoulder. I'll pause it here if we can. So this is that tear. And when we're looking in on the scope pictures, you'll see this arc of tissue misses the rotator cuff that has become detached from the bone. It should be attached here. And that's to our right. So here you go. Here's that arc of tissue curving around here. And I'm using an instrument here to clean up that tissue and to clean up the bone to prepare for that rotator cuff repair. Hopefully we can see that arc right here. I'm cleaning up the bone, and that's where I'm going to attach the tissue. So this is an instrument now that I'm using to reach in and grab a hold of the rotator cuff. This instrument, I'm just pulling on the cuff, bring it over. You can see how I'm stretching it across to see that it's going to make the repair. Here I'm using a needle through the skin to get the trajectory and the placement for my anchors. I need those anchors to be in exactly the right place. It's kind of like doing a sewing job inside of a small box that you can't see. So you want to be able to get all of your sutures in exactly the right place. So we use a spinal needle. This is a little needle that we poke down through the skin to find exactly the right spot to put those anchors in so that we can put the pleats for our sewing in the right spot, in the right place. Once I find the place for that anchor, we use basically a hole punch, and that's what this is. And this is just punching a hole in the bone. This thing has little lines on it to tell us how deep we want to put the anchor down. And this is basically where we're at now. We've got holes in the bone, and this is what our little anchors look like. The anchors that I use are basically made out of plastic. There are a variety of different anchors available. Some of them are made out of metal, some of them are made out of plastic, and some of them are made out of a bioabsorbable material. I like the plastic ones because they're inert. They don't dissolve, so you won't have a failure. Some people use an absorbable anchor, and that can be good. You think that might be all good, but not everybody absorbs those anchors at the same rate. And sometimes they form a cyst around the anchor, and I don't like to have any complications at all. So I use just these plastic inert anchors. And they're MRI compatible. So if we have somebody who has a problem down the road, we can go back and look at the cuff without worrying about the MRI. So here's those two anchors, and this is what the anchors look like. Now these anchors have sutures attached to them. So I'm screwing that anchor down into that bone that I just made with that hole. I'm putting a second anchor in here. In a second, you'll be able to see these two anchors down in the bone with the sutures that are coming out of them. So that's what this looks like at this point. Two anchors with a lot of sutures coming out. The next step is to pass those sutures up through the rotator cuff. So this is an instrument that we use. We grab a hold of the rotator cuff and we push the sutures up through the cuff just like that. We basically repeat that process again and again until we get all the sutures passed through the cuff just like they are there. And that's what we're doing in this process here. There's another suture going through the cuff. This is a little video of arthroscopic knot tying. So I'm tying some of those sutures. You can see I tie the knot on the outside of the skin, and I push the knot down in to tie the rotator cuff down to the bone. We use a little instrument to reach in and cut those sutures. You can see that coming up now. There's a little biter, bite the sutures off. So that's where we're at this point. We've got these anchors placed with the sutures passed through the rotator cuff. Now we need to put 2 more anchors in on the outside. That we're going to take these sutures and pass them down to these sutures, pass them to these anchors and push that cuff down to the bone. So I'm cleaning off a spot on the outside of the arm. So this is way out here now. Cleaning off a spot where these anchors are going to go. And then punch a hole in the bone out there. And this is about 4 millimeters. So that's a small, a very small hole that's going into the bone. You can see the blood coming out of the bone. We like that. And that means that there's nice, good, healthy healing potential in that bone. And here's that second row of anchors that's going in. You can see how that row of anchors is going to tension this tendon. That's what we're looking for. We want our cuff repairs to look like that. And here you can see how that 4 sutures that are coming out here, pushing that rotator cuff down to the bone and completing our repair. It's a piece of cake. You can do this yourself. Now, I did mention earlier that you've got this big bone spur. This is what the bone spur looks like when we're looking at it. We want to make sure we get rid of that. I do that at the conclusion of the case. So this is a burr that I use to scrape away that bone spur. There it is now, nice and smooth. Cleaning up that area, make a nice healthy environment for that rotator cuff so it doesn't get torn again. So that is that. I think probably the best thing to do now is to go ahead and open it up to questions. Rachel, does that sound reasonable at this point?
Yeah, I think that sounds great. So everybody, if you want to start sending your questions in, it looks like we have several in the Q&A chat box. Do you see that at the bottom of your screen, Dr. Dorf?
Sure do. Let me click on that.
And I'm sure we'll have a few more coming in. It looks like the bulk of them are there right now.
I'm clicking on it, Rachel, but I don't see the questions.
The pop-up not opening?
No.
Okay, let's see. It might be opening outside of your window.
Sure. Let me minimize this and see if we can. Oh, here we go.
Got it?
So the first question for the night is from Dr. Norm Numeroff, who is I am a great fan of his, and hopefully he's a fan of mine as well. He's asking me if that was Annabelle in my picture, and yes, Dr. Numeroff, that was Annabelle in the beginning, probably about 10 years ago. So thank you for that. Yes, those are pictures of my kids. I'm very proud of them. So next question, and I'll try to keep folks' names private just in the interest of keeping things private. Next question is from Steve. Hello, if I have a simple tear and do not have surgery, how long till it heals on its own, please? So that's a really great question, and I get questions like that all the time. How long does it heal on its own? That really comes down to how big is your tear? Is it a complete tear? So is the tear completely pulled off of the bone, or is the tear still down on the bone a little bit? It really depends on someone's age. If you're 65 years old and you have had a long history of shoulder problems and you've got a big bone spur in there, is that going to heal on its own and you've got a full thickness tear? Probably not. If you have a very small tear and you're younger and you don't have a big bone spur and you just had a fall on your shoulder and it's a completely traumatic tear, yeah, that does have a chance to heal on its own. So the ability for these rotator cuff tears to heal on their own is 100% dependent on the patient, the type of tear, the extent of the tear. And a simple tear in a younger patient, I would say, how long does it take to heal on its own? 3 to 6 months if it's going to heal. If in a year if you have a very small tear and a year later you haven't had any progression of your tear, you're probably fine. But some of those tears do remain symptomatic, even if they're partial thickness tears. So I know that's a complicated answer to what seems like a simple question, but that's really, it's more complicated than just that. Next question is from Kirk. I'm a 77-year-old woman with a recent ski accident, 4 millimeters through and through tear of supraspinatus by MRI. Minimal impact on function and minimal discomfort. I haven't tried a golf club yet. I'm a right-handed golfer. I'm not anxious to give up the bulk of the summer in a sling. So why not ignore it for now? So as you can imagine, this is, I answer this question 10 times a day, and it's always in the spring and it's always in the fall, and it's people who have a tear and they really just want to try to get through to the next season. So this is a 4 millimeter through and through tear. So what I'm assuming is that this is a full thickness tear. And what that means is the tear is completely, or the rotator cuff is completely torn, although it's not, all of the cuff is not detached. So it's 4 millimeters of tearing and all of the cuff is off, but not the entire cuff is not torn. Minimal impact on function and minimal discomfort. Haven't tried a golf club yet. Not anxious to give up the bulk of the summer in a sling. So why not ignore it for now? So I think that's a very reasonable question. If you have a full thickness rotator cuff tear, the likelihood of that progressing over time is very high. As a matter of fact, the full thickness tears tend to just get bigger with time. We know that. I don't think that in a situation like this, I don't think it's unreasonable at all if golf is your life to play golf for the summer, as long as this isn't impacting you. It has minimal impact on your function and minimal discomfort. Go through the summer, let that cuff, that tear probably exist over the course of the summer. Come back in the fall. And this is not the sort of thing that I would want to wait 2 or 3 years or 2 or 3 golf seasons. I would say come back in October when the golf season around here is kind of wrapping up. We take another look at it and perhaps try to fix this sort of thing in October, November. And that way, you know, you get the better part of your golf season. October, November, we do the rotator cuff repair, because I do think this is a ski accident. It's a traumatic rotator cuff tear. It's going to get worse with time. And traumatic tears do very well with surgery. But I don't think waiting 3 or 4 months while you get the bulk of the golf season behind you, as long as it's not bothering you too much, I don't think that's unreasonable. Now, the alternative to that is to say that let's just say you start playing golf and it really bothers you and you can't play golf anyway. And if that's the case, then I just say, come on in, let's fix it. And you can't play golf right now, so we go ahead and fix it and get you ready for the next ski season. So hopefully that answers that question. Next question is from Sarah. What about other tendons that tear along with the rotator cuff, including the biceps or other? So that's a great question. And one of the things that I didn't talk about very much is other things that we're doing in the shoulder. And we do definitely evaluate the entire shoulder. And the biceps is probably the most common tendon that we're dealing with when we're in there. The biceps tendon is integrated very closely with the rotator cuff. And the biceps can actually oftentimes cause pain in the rotator cuff. So I will very frequently be evaluating somebody's rotator cuff along with their biceps tendon. And if we need to do something with the biceps, we fix that at the same time. Other things in the shoulder that can cause pain, arthritis in the shoulder, labral tears in the shoulder. Those are the sorts of things that we deal with at the same time. Oftentimes those are a little cleanup. If there's a little bit of frayed cartilage, we'll clean that up. If there's some cartilage that's catching or causing a little bit of arthritis, we can clean that up as well. So those are other, that's a great question and something that we definitely evaluate while we're in there. Next question is from Sydney. Do you have yoga practitioners who present with rotator cuff tears? And the second part is, do you have patients who present with tingling arms or numbness of the fingers, nervy stuff? So I'll answer that first question. Do you have yoga practitioners who present with yoga cuff tear or with rotator cuff tears? Yes, a lot of them. And by yoga practitioner, I'm assuming that you are somebody, Sydney, who is doing yoga, but not necessarily a yoga instructor, because somebody who's doing yoga is very different than the yoga instructor. Yoga instructors can be very difficult to take care of because obviously their livelihood is dependent on on their being able to do a lot of these poses, and the poses do put you in positions that can compromise that rotator cuff. I think a lot of this has to do with the age group of patients who are doing yoga. So I see a lot of older patients who are doing yoga. I think older patients are these sort of lifelong athletes who are trying to maintain their flexibility. Yoga is a great way to maintain that flexibility. People get into yoga and they love it. And then they have an injury and they have a rotator cuff tear. I haven't seen a rotator cuff as a result of yoga, but I certainly see a lot of yoga practitioners who are presenting with rotator cuff tears. And then do you have patients who present with tingling arms, numbness of the fingers, or nervy type stuff? And the answer to that is yes. Not normally associated with rotator cuff tears. If somebody has dislocated a shoulder and they have a traumatic rotator cuff tear as a result of a shoulder dislocation, like a patient that I took care of yesterday, as a matter of fact, that can have a lot of sort of nerve implications and problems. However, typically nerve symptoms in the hand or the fingers are more likely to be nerve problems and not problems that are necessarily coming from the rotator cuff. The nerves that are coming from the neck down into the fingers sort of bypass the cuff. They're not in close proximity to the rotator cuff. So they're not usually involved with rotator cuff tears. So next question is from Scott. Scott has, does the cuff grow back to the bone after the repair? So that's a great question, Scott. The whole goal of this repair is to get the cuff to grow back to the bone. The one thing that's a little bit confusing about that is the cuff has very little ability to actually grow down to the bone. It's the bone that is growing up into the rotator cuff. So the first part of that video you saw, I was using an instrument to clean off the bone. The area where the rotator cuff attaches down to the bone is called the footprint. The footprint of the rotator cuff is very important in that the bone is actually throughout the footprint is growing up into the rotator cuff. So after we clean that area off, we actually take that burr, the same burr that we use to get rid of the bone spur, and we make that area bleed. And once we get that area to bleed, or get the footprint to bleed, then we put the anchors in, and then we push that rotator cuff down to the bone, and then that bleeding bone invades up into the rotator cuff. And that's how this all works. Those sutures will only hold that rotator cuff down for a certain amount of time. And eventually that cuff and that bone have to become one. They've got to integrate. And the way that happens is the bone actually invades up into the cuff. Next question is from Jody. Is a diabetic patient an issue for this type of surgery? So the one thing that is interesting about diabetics, we do know that it is more difficult for diabetics to heal. The results of rotator cuff tears in diabetics are not as good in general as they are for patients who are non-diabetic. However, diabetics who control their sugars well and are active participants in their therapy can still do very well with rotator cuff surgery. So in my practice, I have not had a whole lot of issues with regard to the healing of the rotator cuff in diabetics. A separate issue is diabetics are more prone to getting stiff. So we have to balance always this ability to start physical therapy with somebody who's going to heal a little bit more slowly with a concern for them to have that repair fail. So depending on the type of tear, we consider all of those things with regard to how we're going to fix it, how quickly we're going to proceed with the physical therapy program, and making sure that we get things moving so that somebody doesn't get stiff in the meantime. So Jody, I hope that answers your question. Next question is from Mary Jo. Mary Jo, can you just remove the bone spur? So the answer to that question is yes. Can you just repair the bone spur? The bone spur is certainly a part of the problem. And if you got somebody whose primary problem is impingement and they don't have a rotator cuff tear, then you can just remove the bone spur, and those patients do fantastically. The rehab after that is less significant, and patients are back to full duty sports activities relatively quickly. Now, if you already have a full thickness rotator cuff tear, the problem with doing that is that the rotator cuff Once it starts to tear, it's getting pulled apart, and a little small tear here propagates, and that tear over time gets bigger and bigger and bigger. So the cuff is very dependent on its integrity as a whole in order to maintain its full function. So once you had a little hole in it, it's hard for that rotator cuff to do its function, and then they often do fail if we don't fix them. So that's the problem. Now, an anonymous attendee asks me a very common question: can a partial tear of the rotator cuff be surgically repaired with a patch instead of anchors? Now, this is a whole nother webinar, and one that I would love to do at some point. So there is some new technology out there that is essentially a patch that we place over partial thickness rotator cuff tears that is very effective in treating these partial thickness tears. So sometimes the rotator cuff can be partly worn away by that bone spur. And so that makes it a little bit difficult if you've got somebody who has a partial thickness rotator cuff tear. Most of the cuff may still be intact, but unfortunately they're having pain from that partial thickness tear. So one of the things we would want to do, as Mary Jo pointed out, we would want to, of course, go in and remove the bone spur. But is there anything that we can do while we're in there to try to augment that partial thickness tear? And the answer to that is, over the last 5 or 6 years, I'm doing more and more of these repairs where we're actually putting a patch on top of the rotator cuff. And this patch is a very thin collagen matrix. So it's cartilage that lives on top of the rotator cuff. And over time, the rotator cuff grows up into that patch and thickens the patch, or thickens the cuff. So yes, the answer is we do treat partial thickness rotator cuff tears with a patch. Next question from Lloyd. I had 4 rotator cuff operations. I'm over 70 and still do rehab exercises using the armbands and small weights, 2 and 5 pounds. Is there anything else that I can do? So 4 rotator cuff operations. I'm not sure if that means 4 rotator cuff operations on one arm, or 4 rotator cuff operations on 2 arms, or maybe 3 and 1. But it sounds like that's probably what you should be doing is exercises, light weights. If it's 4 rotator cuff surgeries on one shoulder, and you're still having symptoms, yes, that's a bigger issue. If you've got 4 rotator cuff surgeries and you're doing very well on these sorts of things, using the armbands and small weights is maintaining your strength and maintaining your range of motion, then I think it's perfectly reasonable to continue doing that. And I would encourage that. Hopefully you're doing well. This is a name I recognize. Bob, how does the bovine patch work compared to the anchor repair? So, Bob, that's a great question. They are, the results are actually quite comparable, but like we've talked about, they're sort of for different problems. So the patch is for a partial thickness rotator cuff repair. The anchors are for full thickness rotator cuff repairs. If you look at the actual outcomes, the outcomes are very similar. The clinical outcomes are very similar. So we're talking about 85 to 95% success rates for the anchor repairs. In my practice, I think the patch repairs are probably a better success rate than the anchors, still probably in that 85 to 90% range. However, again, they're sort of comparing apples to oranges because they're different types of tears, one of them being partial thickness and the other one being full thickness repairs. Now, the one thing that is nice about the patch that I like is that all of the studies that are looking at the results of the patch are MRI studies. So they're actually studies looking at the thickness of the rotator cuff prior to, by MRI, just looking at MRI, looking at the thickness of the rotator cuff repair prior to the patch, and then after putting the patch on. And what they found is that the thickness of that rotator cuff over time increases significantly, anywhere from 2 to 3 millimeters in thickness. So they're not clinical studies. These are really just MRI studies, and they have shown great success in increasing the thickness of the rotator cuff. Those studies are hard to compare with the full thickness repairs simply because they're different. It's a little bit of a different animal. Rita, this is my favorite kind of question from Rita. Thank you. Excellent presentation. Former patient of VSO, and hopefully, Rita, not a future president of VSO. Okay, so next question. Bob is saying, why does biceps tendon damage seem to occur along with rotator cuff tears? And then his second part of his question is also, I'm 4 weeks out from a large repair. Can you talk a little bit about the rehab process? So let me start first with the biceps tendon component, and then I'll talk about the rehab. And then the next question is actually from Chris. Is there a typical time of recovery for surgical repair? So I'll be able to address all these questions at the same time. So why does biceps tendon damage seem to occur along with rotator cuff tears? There's two reasons for that. The primary reason for that is, unfortunately, these two things being related are mostly related to age. So tendon damage and tendon issues tend to come up as you get older. That's the primary reason why tendon damage occurs along with rotator cuff tears, because those are both tendons. They're in the shoulder. They're both related to age-related degeneration. They're both very common injuries in active older athletes, and that's why we get this. So they're very common like that. The other thing that can happen is the biceps runs right next to one of the rotator cuff tendons, in particular the subscapularis. The biceps runs in a little groove, and it's held in that groove by a ligament. If that ligament fails, the biceps tendon can come out of that groove and rubs on one of the tendons of the rotator cuff and can tear it. So that's the two primary reasons why they're related. Number one, the biceps itself can actually damage the rotator cuff if it comes out of its groove. And secondly, both of those things, biceps injuries and rotator cuff injuries, are both age-related degenerative processes in the shoulder. So I am 4 weeks out from a large tear. Talk about the rehab process, and then Chris, is there a typical time of recovery for surgical repair? So this is a great question. Let me just go through my rehab process, and I'll start by saying the rotator cuff, the rehab process from a rotator cuff repair is a lot more complicated and a lot more difficult than the surgery is for me. So when you come to me and we do rotator cuff repair, it's a long relationship that we have together. I wait a full 4 weeks before I start patients down the physical therapy process. The most important thing that's happening in the rotator cuff after we do our repair is that tendon and that bone are coming together. In particular, the bone is growing up into that rotator cuff tendon. So that's the most important thing. We have to protect that tendon and that bone so that they will heal together. 4 weeks out from surgery, for the first 4 weeks of surgery, we start some very gentle stuff where we're doing sort of shoulder shrugs, gently moving the arm around, just keeping things active. We work on the elbow, we work on hand range of motion, decrease the swelling, decrease the pain. But again, the first 4 weeks, the most important thing is the start of the healing between the bone and the humerus and the rotator cuff. At 4 weeks, we start a physical therapy protocol that starts with passive range of motion, which means you're going to the physical therapist and essentially they're moving your arm around. The reason we do that is we're trying to get the joint to move without necessarily putting tension on that rotator cuff. So the joint is getting moved around without pulling on that rotator cuff repair. That process of passive range of motion is another full 4 to 6 weeks. And if it's a big full thickness rotator cuff tear, or perhaps it's many different tendons that we're fixing, that can be at least another 6 weeks. So we may not start any active range of motion until we're about 10 weeks out from surgery for a very large repair, or 8 weeks out from surgery from a smaller repair. At the 10 to 12 week mark, we start more active range of motion where you're actually moving your arm up by yourself or someone else is moving it up and helping you a little bit. That process is active assisted range of motion, goes on for anywhere from 4 to 6 weeks. And then by 12 weeks, we're really starting a gentle strengthening program. So the total process for typical rotator cuff repair is about 6 months. But I tell almost everybody that even at 6 months, you still have a long way to go. It's just the gains after that are smaller and they take longer. So even at a year, you're still probably making some progress. And I think most people will, at 2 years after their surgery, look back and say, hey, you know what? I'm actually better now than I was a year ago. So the curve is very steep in the beginning. well, very flat for the first 4 weeks anyway. And then it's steep for a while. And then after a while, it flattens out again and people make gradual, slow improvements. So Bob and Chris, I hope that that answers your questions. Next question is, could you discuss reverse shoulder replacement surgery? So I can discuss reverse shoulder replacement surgery briefly. In patients who have shoulder arthritis in combination with a massive rotator cuff tear, the only option for those patients, if they can't move their arm around, some of those patients can have shoulder arthritis, a massive rotator cuff tear, and still be able to move quite well. They oftentimes will require what's called a reverse shoulder replacement. And those reverse shoulder replacements are the shoulder's a ball and socket. And what you're doing is taking the ball and the socket where this would normally look like this. And you're putting a ball on the scapula. You put the socket on the ball on the humerus, and you replace that joint with what's called a reverse shoulder replacement. Those are reserved for patients who have, again, shoulder arthritis and an irreparable massive rotator cuff repair. And what that essentially does is you're replacing the function of the rotator cuff with the function of the deltoid, and you're giving that shoulder the opportunity to be lifted again. So I hope that answers your question, Wayne. It's a complicated question with with a full webinar that could go into a reverse shoulder arthroplasty, and would be a good one to talk to my partner, Max Sider, who does those. I don't do those anymore. Next question is from Matt T. Is popping a good indicator of rotator cuff issues? Example, when hugging others. First of all, I would highly encourage hugging others. I think that's a good idea no matter what. Well, COVID safe, of course. So within your bubble, or vaccinated individuals. And thankfully, most of my rotator cuff patients have been vaccinated because they're all in this a lot of people in the older population who want to get out and do things. So is popping a good indicator of rotator cuff issues? I would say no. I would say popping is not necessarily something that someone comes into my clinic and says, hey, my shoulder's really popping. The first thing that comes into my mind is not necessarily rotator cuff. Biceps very commonly presents with popping. AC injuries, which is injuries up in here, present with popping. Shoulder arthritis presents with popping. I don't normally get concerned with popping or sounds from these joints unless they're painful. So painful popping, yeah, that may make me concerned. But I don't think that popping in the shoulder or any joint in particular makes one specific diagnosis pop out. No pun intended, more than another. Scott's next question is, and as you can imagine, a very popular question about how long will it take to recover to golf form post-op. So I actually have a designated return to golf protocol. We start the return to golf protocol at about 5 months after surgery for somebody who has a full thickness rotator cuff tear. Some of golf can actually be really great rehab, and I love to try to get people back to the stuff that they like to do. So putting and chipping around the green can be a great way to sort of work on some of that shoulder range of motion. It's also a great opportunity for you to work on your short game. And then we have a return to golf protocol. How long will it take you to recover to a scratch golfer? If you started off as a scratch golfer, I would typically say that's 1.5 years. That's an 18-month project to get back to your previous golf game. But I have a lot of patients who are back at 1 year and back to their previous golf game. I also have patients who tell me that they're playing better golf than they ever had. I like to give myself credit for that, but I actually think it's because they're taking it easy and swinging a little bit more gently because they're nervous, and as a result, surprise, surprise, their golf game gets a little better. Or it might just be that they spent the time sort of between that 4 and 6 week or 6 month mark working on their short game. So as you know, that can be critical to getting your golf score back. So it's a long process. Next question is from Erik. How do I set up an MRI to get what you will need to see? Do you need to see me first? The pain is manageable unless I'm playing volleyball. I did have you put a steroid shot in me a couple of years ago, and now thinking about a bone spur maybe. So the best way to do that is actually to come in and get an MRI. Come in and see me, and then we can order the MRI. And there's a couple of reasons for that. The primary reason is that insurance companies will not pay for an MRI unless you come in and see us, and we can help with that process for getting that MRI approved. So that's really the best thing to do. Says, I did have you put a steroid shot into me a couple of years ago, thinking a bone spur. So hopefully it is just a bone spur, but if you come in, we get an MRI, take another look at your shoulder, take a look back at those x-rays, see if there's a bone spur in there, evaluate your rotator cuff clinically, see if this, if there's a strength issue, and then consider getting an MRI. So that's the primary reason I really do like to see people before we go ahead and order the MRI. And then this is another question. Okay, so this is a follow-up question from Wayne, who had the question, can you discuss reverse shoulder replacement? And he says, by the way, I have a full thickness tear that's been damaged for years. I'm 66 years old. Wayne, it sounds like a reverse shoulder might be a fantastic option for you. So next question is from Scott. Have treatment options improved in the last 3 years? You told me my tear was not repairable 2.5 to 3 years ago. The answer to that is not really. If it wasn't repairable 2 or 3 years ago, it's still probably not repairable. We have done years of trying to repair these full thickness rotator cuff tears, these retracted full thickness rotator cuff tears. The problem is not necessarily getting it repaired. The problem is the muscle atrophy and the muscle fibrosis of the muscle in the shoulder actually becomes very it's dysfunctional. So even if we do reattach the rotator cuff, it's the muscle damage that's already done. So I would say that if I saw you 3 years ago and your cuff was irreparable then, it's probably not any better at this point. We just don't have ways to rehab that muscle. Next question is from Mark. I am 53-year-old male. In 2011, had a shoulder rotator cuff fixed. And Dr. Cunningham did my first surgery. Dr. Hatzidakis did my second surgery. In the last year, I'm having a lot of pain in my shoulder and my neck. Is it normal to continue having trouble with a rotator cuff injury? Great question. At 53, this is tough. So we have patients who have had multiple rotator cuff surgeries. I've obviously been down this path myself with patients who are young and active and continue to have rotator cuff symptoms. No, I would say it is not normal to continue to have trouble after a rotator cuff injury or rotator cuff repair. If it was normal to continue to have problems, I wouldn't continue to do the surgery. That being said, that some of these problems are just very difficult problems, and not everybody gets 100% better from every single repair. And Dr. Cunningham and Dr. Hatzidakis are both great surgeons, great shoulder surgeons. So I have, we all have our patients who don't do well after their repair. And I would certainly be happy to see you. We can talk about options and see where you're at with regard to that rotator cuff and failed rotator cuff surgery, or patients who are continuing to have pain after even a successful rotator cuff surgery is a difficult problem, but one that we are used to dealing with, but thankfully don't have to deal with very often. Susan, any specific questions to avoid further discomfort with yoga? So one of the things that causes problems with patients who are doing yoga is downward dog. And the reason that is that as you're on your hands or doing a plank position, that rotator cuff is pushed up into that, or the humerus is pushed up into the acromion, and that can push on that bone spur. So obviously maintaining flexibility, maintaining range of motion, that's probably part of the reason why you're doing yoga. And so suggestions to avoid discomfort with yoga is avoid poses that put an excessive amount of pressure onto that shoulder. And you can let pain be your guide with regard to that. And I wish I had a better answer for you, but that's kind of where it's at. Maintain your range of motion and avoid doing stuff that hurts. Next question is from Ernest. What therapy helps the bone grow back into cuff tendon? How long does this take? Diet or vitamin supplements appropriate to help? Great questions. So what therapy helps the bone grow back into cuff tendon? I don't think there's actually therapy that helps that. I think that the therapy, that's just a process of time. The bone needs to grow into the tendon, and for different patients, that takes a different amount of time. Younger patients, going to happen faster than older patients. That time frame is probably in the 4 to 6 month range for that to really have taken good effect. A lot of that happens in the first 3 months. There are a lot of the therapy that we're doing down the road is not necessarily to stimulate the bone and the tendon to heal together, but it's to help the fibers of the rotator cuff. When we saw the pictures of the rotator cuff, you see that those fibers are kind of in a line, and we're trying to get those fibers to line up over time. So one of the most important things that's happening in that process is the fibers of the rotator cuff are actually lining up. So the strengthening exercises that you do and the gentle, active, and passive range of motion exercises you're doing down the road are trying to get those fibers of the rotator cuff to line up. And that's a big part of that process. Diet or vitamin supplements appropriate to help. So things to help, I encourage my patients to take vitamin C. Vitamin C is important for collagen. Collagen is a big component or a big part of that rotator cuff. So vitamin C is one of the things I recommend. Otherwise, from a vitamins perspective, I don't necessarily, I tell my patients to eat healthy, take good care of yourself, get plenty of sleep. Most of my patients are very conscientious of these things anyway. So I think eating healthy, getting your protein, vitamin C may be helpful. And that's kind of where I'm at with regard to vitamins and supplements to help. Next question is from John. How old is too old for repair? That's a great question. And there's studies out there that are looking at rotator cuff repairs in patients of different ages. We used to think that 70 was old for a rotator cuff repair. We used to think that 65 was old for a rotator cuff repair. I have done old rotator cuff repairs in 80-year-olds and had them do absolutely fantastic. So it really depends on the patient, how healthy they are, what activities they're doing, how debilitated they are. If somebody can't lift their arm up and they're an active, healthy 82-year-old and they can't do the things they love to be able to do, and they fell down and tore their rotator cuff, I'm happy to fix that patient. I think they'll do great. We have to be careful with regard to how we approach our therapy protocol, but to me, that's an opportunity to make for a home run. We just have to be careful with how we do the repair and the post-op. Next question is from Kirk. How do you have to sleep sitting up, and if so, for how long? Patients do feel more comfortable sleeping in a sitting up position. So that reclined position or sitting in a recliner is more comfortable. I don't have that's really up to the patients. I'll have patients who will sleep sitting up for 6 weeks. I'll also have patients who sleep sitting up for the first 3 or 4 nights and then they're done. So it's really up to our patients. Next question is from Natalie. Natalie and I went to high school together, so I know she's very, very young. Natalie's question is, how long after surgery and therapy, which sounds like at least 6 months, could you ski and mountain bike? It really depends on the size, Natalie. Depends on the size of the repair. Depends on the extent of how well the therapy went. Natalie says at least 6 months, and I would say that is typically true. I do try to get people out into some gentle activities earlier on in the process. So if somebody's a great skier and they want to go skiing at 5 months and ski groomers and take it easy, and they've got someone to help them pull their skis out of the gondola car, then I'm happy with that. Similar with biking, for example, if someone wants to ride a bike on the indoor trainer at 6 weeks, I even let them do that. That's 6 weeks post-op. Probably on a bike outside at sort of 4 to 5 month range, not necessarily mountain biking, but perhaps mountain biking on smoother trails or roads, or road biking, as long as, again, you have somebody to help you get your bike up onto the bike rack and off of the bike rack. I have seen patients who have torn their rotator cuff in that process. So Scott has another great question. He says, thank you for the information. I love that, Scott. Thank you for attending. And then one last question, is there any evidence that PRP during or after surgery helps the repair process? So there are a number of studies out there looking at PRP. So what PRP is platelet injections that we'll use to augment rotator cuff repairs. There is some evidence that PRP may be helpful for some patients after a rotator cuff repair. There's more sort of biomedical evidence. So looking at some of the biology that's in the shoulder after the rotator cuff repair. Clinical studies haven't shown a significant difference between repairs that have used PRP versus repairs that have not. I don't typically use PRP during the surgery. I really am more, PRP is all about platelets. Platelets are your body's response to bleeding. Your body's response to bleeding is to release these platelets. They stop the bleeding, and at the same time, they release these growth factors, and those growth factors help with the healing process. I try to get that bone to bleed really well. If we can get that bone to bleed really well, then the rotator, or the bone will grow up into that rotator cuff. And I feel like the platelets are there sort of naturally. So that's my answer to the PRP question, is that I try to stimulate your own bone to do the healing rather than taking blood from you and then injecting it back into that same place, which is essentially the same thing. So that is all of the questions we have. Pretty excited to be able to get through all those questions. We've been on here for an hour and 15 minutes, which I know is a little bit longer than we were supposed to, but there's a lot of great questions. Is there anything else, or Rachel, anything else we want to do? I know I am on call and the hospital has been calling me. So if there's nothing else, I would probably need to go take care of somebody.
Yeah, no worries. We did have a few more in the chat, but I think we can get to those on a written format and kind of answer those later on. So not a huge deal. There's probably like 10 or so. So why don't we take a pause for now, and we will get those answered and posted in the blog. And then I wanted to let everybody know, because I know that there was a question about shoulder replacement. We actually are running a webinar on shoulder replacement surgery with Dr. Sider on May 20th at 6 p.m. Josh Jones of Avalanche Physical Therapy will be on that as well. I don't have a link for that yet, but I will have that posted tomorrow. So if you're interested in learning about shoulder replacements, mark your calendars for the 20th.